Hello and welcome to the Health Oddity Podcast, episode 254. Now, we are joined by a returning guest today, Mr. David Adkins, or Dave Adkins from Principle Physiotherapy. How are you doing, Dave? You okay?
Yeah, very good, thank you. And yourself?
Yeah, very good, thank you. Yeah, very good. I'll touch base with Pete in a minute because we've got a big weekend coming up. But before we get started, I was going to say, if you haven't listened, I was amazed. I looked back. The last time that Dave was with us was episode 140. So that was 104 weeks ago. So that's
2 years.
exactly 2 years. Exactly 2 years ago, I think, was the last time. That doesn't feel that long ago, does it, Dave?
It's a good stat.
It's a good stat.
Yeah.
Yeah.
Yeah, no, it
That's
doesn't feel that long ago, to be honest. No.
yeah, exactly 2 years ago. So I would say, I mean, today what we're going to be doing is we're going to be going through with Dave and discussing some kind of common training injuries or common training concerns people may have that they then maybe go to see a physio about, or maybe go to their doctor about, and maybe end up at a physio with. We're going to talk about some of those things with Dave today. But the last episode that we did with him, episode 140, was really interesting because we talked all about kind of Dave's career and where he started and working in like Great Ormond Street Hospital in London, and kind of how he got to be where he is today. So if you haven't listened to that, that's a good one to go back to and listen to 140, because today we're not going to obviously go back over kind of the stuff we covered in the first episode. This is going to be a very kind of targeted episode talking about kind of training injuries and conditions and issues that people may have as they start to get a bit older with training. So we're going to go straight into that in a minute. But I'm just going to touch base with Mr. Peter Lamp because we're at the moment, we're in the middle of a bit of a heat wave in England, aren't we? It's close to, it's about 30 degrees here. And I just looked up for our American cousins. That's
That,
86
that's that's what happens in a heat wave.
t-shirt tan, t-shirt tan. Okay. So about 30 degrees C is about 86 degrees Fahrenheit, to give you an idea. I know that's not a lot for some of you who may be listening in California and Vegas and these hot places, and Arizona and those sort of places, but it's pretty hot for England anyway, 30 degrees. And we have got the walking weekend this weekend, Pete. So tomorrow evening, as we're recording, I'm going to be seeing you down in Bath. And
Yep,
we've got a lovely weekend of walking down with you, haven't we?
yep. We're going over Salisbury Hill tomorrow, or Little Salisbury, as we should call it. We'll get letters.
Okay.
Um, yeah, but that's the one in the Peter Gabriel song. So we're going walking over that, and there's like a little red nature reserve in that. It's going to be 28 degrees when we start at 4 o'clock. So bring plenty of water. And then
Yeah.
we've got Elise is coming
Yeah.
on Saturday, so a friend of the show. She's bringing some Welsh bloke with her as well. I don't know who that is, but
Yeah. She said that to me. Yeah.
he's coming along, and he's also been asking if there's any opportunity for wild water swimming, and I'm just like, no, it's Bath. There's no like, it's called Bath, but there's no water. So and also if it's this hot and that the water that is around, you wouldn't want to swim in it.
No.
Um,
Yeah.
and there's a lady called Fiona as well coming from Quentin's gym as well. It's so
Excellent.
far. She said she can still do it, so she's coming from Quentin's gym as well. So that'll be cool.
Right. No,
Yeah.
really looking forward to that. That's going to be an excellent weekend. So yes, that'll be a great weekend this weekend down in Bath in Somerset with Peter Lant and Walk Bath and Walking Solves and Unique Results there for their walking weekend. Now, Mr. David Adkins in the physio room, he's sat there at the moment. We are going to talk about some issues that you get presented with. You do work out of Unique Results, so you deal with mainly, I would say, people probably around sort of mid to late 40s plus, probably is kind of fair to say, with the clients that we have. But we've just had a little brainstorm and made a list of some conditions and some injuries that people may have as they're in their 40s, their 50s, and later. And they may just develop these conditions, or they may be caused by like a training injury or a training niggle or something like that. What would you say is your most common complaint, or your most common issue that you deal with people within your physiotherapy practice? Is that something you can answer?
Yeah, there's always one that seems to be the most common, and then there's a few that sort of sit behind that. Back pain is always the most common condition that people come to physio doctors with, and they also have like the most time off work with as well. So yeah, certainly back pain is the most common, and then you have things like knee pain, neck pain that also are very common, but just slightly behind the back pain.
So I mean, we've spoke about this before, haven't we, Pete, on the podcast, where back pain is, I know a lot of people have time off work, like you mentioned, with back pain. It kind of has just got this overarching umbrella kind of label, I suppose, of back pain or lower back pain, which most people have probably experienced in their life at some stage, either acutely or more kind of chronically. Have you had back pain, Pete? Have you ever had any?
Not. It's never kept me off work or anything. But when I started, when I finished work, when I got made redundant from an office job, and if I ever went on if I did a 5 or 6 mile walk, I'd get a really achy lower back. And I don't anymore. I can walk for forever now, and I can, but it's like I've been lifting weights and stuff like that, but doing it gradually. But I've also done it wrong in the past as well, and ended up with an achy back. So yeah, I have, but it's never been like hugely debilitating for me. But then this was all by my sort of mid-30s. I started to do something about it, so I probably caught it at the right time, I think.
Yeah, I know I have. Not for a lot, not really for the last 3, 4, 5 years, but I had a real patch of time where my back was really. I don't want to, you think I've got a weak back or a prone, like we say with some of your clients, Dave. You don't want to say that. You don't want to kind of label yourself, but
I've got a fat back, like Alan Partridge.
No, but you know what I mean. Like a back that you're a bit prone to injury, or you're a bit wary of, or you're a bit nervous about, And
I think that comes a lot from education. And in the 70s, 80s, there was a lot more doctor-led treatment for back pain, and they would often advise long periods of rest in like bed rest. And over the years of research, we've found that actually staying active and keeping moving is the best way. But those old theories and old approaches are still quite stuck in the society's approach to managing back pain. So people are very cautious, and they also are very protective of their backs when they have it, or if they are doing an exercise such as like deadlifts. People become quite scared to progress, when actually those exercises are not inherently dangerous, and they actually can benefit you in the long run. If you're stronger, then your back can tolerate more. So it's changing people's viewpoints on what back pain is, to become more confident, really.
And I know it's. I'm sorry, go on, Pete.
Do you think this is something I've seen? I saw Adam Meakins describe it like this, because people hear about I've got a disc out, or I've got a a slip disc or whatever, and there's all these terms that fly around, and when that conjures up something in your mind, doesn't it? And you're like, oh, that's a really bad thing. And then people also use donuts with and they squeeze them and go, the jelly comes out, and that's what's happening with your disc. But he said a disc is like a tractor tire with bubble gum in it. It's more like that, which is try and break that. It's going to be quite hard. So is a lot of it kind of, people have got a sore back, and then they conjure up this image of like blowing the spine apart sort of thing. So they get really wary of it. Is that part of it?
Yeah, I'd say so. But there was, over the years, a lot of people have had scans because of back pain, which have then shown disc bulges and other structural changes within the spine. And because you've got back pain and a condition seen on an MRI, they connect the dots. And sometimes they're too quick to say that that's the reason for your back pain. And then there's some people that will think, right, I need to go and strengthen my back to protect it. But there's a lot of people that say, I can't do that because of my disc bulge. And it's really down to the individual's personality and what they've been taught as well. So yeah, it's really difficult when somebody comes to you and says, I've got a disc bulge, so I can't do these things. And if you can find a way to encourage them to try them and progress, they often do really well, because it's not normally the disc on its own that's causing the problem. It's how they live, the job they do, the types of things they get up to. So there's many things that you can change. You may not be able to change the disc bulge, but you can change their strength, their flexibility, and all things like that. So it's definitely a mindset change with back pain.
Yeah,
so I think it was kind of, and this is from my experience as well. I think often, I know it's very difficult to have a blanket approach to something, because obviously you treat the individual patient and everyone's going to be slightly different. But there used to be this, certainly with like GPs, if you went to see a GP with back pain, there was a blanket kind of recommendation to basically do something like yoga, Pilates, stretching, and a lot of the kind of, I'll use the term soft, but more mobility based, just trying to get the movement going a lot more. And then you get lots of people who maybe reach out and say, I've been told I need to do yoga, or I've been told I need to do Pilates, or I've been told I need to do this as a kind of, and as a general kind of course of action, I suppose. Is that what I know that's kind of seems to be what the advice people, I don't know if they still get it, but, and I know from my experience, when you do, we've had, what's Morrison? Is it Tom Morrison?
Tom Morrison, yeah.
Tom Morrison on as well. And a lot of people think, well, because if you do lots of stretching and foam rolling and stuff like that, it does make you feel better in the short term. You do get an instant kind of pain relief and you feel good. But from my experience, it doesn't kind of do anything to solve the problem in the long term. I don't know what you feel, how you see things going.
I don't have a strong view on saying, oh, you should go down this route. I think that for Pilates and yoga, they have a combination of strength elements and mobility and stretching. So it does have a good mix. What it doesn't have is the resistance. So I always encourage people to try, if they feel able to, and start lifting weights and resistance training, not only to improve their back pain, but also to make them stronger. Their bones will be stronger, their muscles will be stronger, so that if they do go on the weekend to help somebody move something, because it's often people get back pain when they decide to do something they haven't done for a while. So maybe like a whole weekend of gardening, or they're moving house, or they try and lift something on their own. If you're stronger, then you might get away with it a little bit more. But a lot of people avoid strength training and only do maybe mobility. Some like more mobility side of things. So I totally agree. You need both. You can't just do one or the other.
Is there also the thing, like if you're doing gardening or something like that, if you're stronger, the likelihood is if you move and you go like tweak and you're like, oh, you kind of do a movement that your body wasn't expecting, or your brain wasn't expecting, you kind of that can tweak something, can't it, and make you sore, like give you some sort of niggle for days or weeks. Whereas if you're stronger, is it less likely to happen, do you think, or does it make a difference?
I think it's how you respond after the tweak, because if you get that sharp pain in your back and then you go and lie down and then you spend days being careful, the likelihood is that problem will last longer. The person that has learned how to manage those problems, they will get moving quickly. They might start to do some stretching and mobility, try and get back to their normal activities quicker, and then that will speed up their recovery. But I'm not saying that the additional strength won't speed up their recovery, but I see really, really strong people coming to clinic, but they have terrible coping strategies, so their back pain takes longer to recover from.
That's interesting, because a couple of years ago I don't know what I'd done. Like my back was fine, and then I got up one day, my right side, it was just achy to the point where it was stopping me. Like I'd stop breathing, I'd be like, I can't, like, oh, it's so even just brushing my teeth and then like spitting the toothpaste out in the sink, I was like, oh, that's so, and I couldn't like bend down to touch my toes at all. So I'd just take the dog for a walk, and I was walking around a field, and then I could bend down and touch my toes. Like I'd just keep testing it, and then I'd get home and like sit in a chair at a laptop for like half an hour and do something, and then stand up, and I was like, oh, it's back again. So I just monitored that over the next few days, and it kind of went away.
Yeah.
But it was interesting. That was horrible.
And you were pushing into pain as well. Where some people wouldn't dare push into discomfort, where you were gradually trying to push the boundaries and stretch a little bit further than last time, that allows the muscles to relax and stretch. Somebody that avoids that completely will end up having muscle spasm around their spine for longer.
Yeah.
They might consider that as being, they've got a worse injury than you, but it's really the same level of injury, but a completely different coping strategy.
Yeah.
So yeah, so lower back or back pain is kind of like the main one that you would say that. And like you say, because people they may go to a physio, they may go to a chiropractor, they may go to an osteopath, they may go to have acupuncture or any of these kind of therapy type things. And I know the difference. I think we spoke about this last time you were on. You've got kind of therapies that are kind of done to you, and then you've got therapies that are kind of where you're involved in the process, and it's teaching you to maybe, like you said, coping strategies and actually where you are you're involved in your own healing and your own recovery, really. I mean, on the whole, and again, it's really difficult because we can't ask absolute questions. There's no yes, no, really. But on the whole, therapies that are done to you and give you a kind of a pain relief or an improvement in the short term. Do you feel that, again, maybe there's a combination of therapies that are done to you and then a longer term strategy that you can do yourself? I mean, how does the balance of that work in your mind?
I've got a strong bias towards exercise, but where I found that it doesn't always help, or it's not always the right time to introduce exercise, I've returned back to having a more hands-on approach, and that enables that patient to become more confident to move. And maybe there's a psychological element to treatment as well that gives people the confidence that something's been done, and then they feel like they're able to try the next step, which is the exercise. But it's very individual to the patient. Sometimes someone sits down and explains their back pain, and I feel confident enough to take them straight into the gym. I might even get them on the treadmill and get them running if they're a runner. So it really depends on who's sitting in front of me, and also what their bias is, because if they've only ever had treatment, they won't respond well to me saying, right, let's go straight into the gym. So I try to match the treatment to the person in front of me with the end goal of getting them into the gym.
Yeah, because I think long term, you have to adopt some kind of different way of doing things, don't you, as an individual, as taking personal responsibility. Because you hear it all the time as well, I'm sure. But I speak to people and they say, "Oh yeah, I've got a bad back. It's just like every 6 months, I have a flare up, or it just goes out." Like Pete said, my back goes out every 6 months or once a year, and I just have to deal with it when it happens. But I think if they change their lifestyle and have a longer term coping strategy, then the frequencies of any negative things will probably be less. And like you say, when they have those negative things, they'll be able to recover more quickly and get back onto their day-to-day stuff. So no.
Yeah, I totally agree. I think that it's important. I think the discussion we've had is just generalized back pain where you've overdone it, but there are some very specific conditions, like a disc prolapse, or somebody's got inflammation around the facet joint, that's going to take an extended period of time to recover from, and that has to be respected. You can't just exercise that problem away. Emma, I know she's happy for me to speak a little bit around this with other people. She had a disc prolapse and lost the power in plantar flexion, so the ability to push up. And I know that you worked with her for a long time, and it took a long time before she was able to start putting more power through her foot and then start lifting again. So when somebody has a structural diagnosis like a disc prolapse, you can't just exercise that away. That has a time to heal, and you can't be pushing beyond that, because you'll cause more damage, and then long-term issues, like she wouldn't have been able to return to pushing off. She wouldn't be able to lift again. Whereas we respected the condition. You built her back up at a very steady rate, and then she was able to return to heavy lifting now, which is fantastic.
Yeah, so I think, we should say that to everyone listening, that today we're going to be talking about general kind of advice or general kind of things, but this is not kind of direct medical advice to anyone listening. You really, if you do have a problem, you need to go and see someone locally. to get it properly diagnosed. You know, you don't want to kind of just.
Do we know? I might look it up if you don't know, but do we know what the stats are on that between like general back pain that you can actually go and just, you know, like we've just said, you can go down to the gym or strengthen it or do whatever to sort it out, an actual structural damage? Do we know what because I think a lot of people might think I've done something when they actually haven't. But we also don't want people going away thinking, oh, I'll be fine, like we've just said, and then when they actually have done something, you know what I mean? So do you know the stats behind it?
So back pain is probably the most researched, and there is a consensus of a high percentage, so 80 to 90% of it being a non-specific. But then there's a large group of physios and professionals that disagree with that term being used, because every problem has a specific cause and needs a specific treatment. For me, I don't jump into that argument too much, because I just see people on an individual basis. But if you look at the research, 80 to 90% will be non-specific. Maybe the next 5 to 8% will be a very specific structural cause. So that could be disc prolapse, that could be degenerative changes, there could be narrowing of the joint space, which is causing compression on a nerve. And then there's 1%, which is a medical emergency. So that's the difference between the levels. But when we're talking about back pain, I'm really talking about that sort of 80% of people that if they do the majority of the right things, they should feel better and be able to move. There's that smaller percentage, like 5, 6 to 8%, that need medical management and can't just exercise the problem away.
And how much does scoliosis come into this? Because I've heard lots of different things on that as well. Like some people are like, there's certain things you can do with scoliosis and there's certain things you can't do. And then other people will say, well, you can do pretty much anything you like because it's just your back. And most people have got a bit of scoliosis anyway. Nobody's like straight. So like, is there, what's the kind, because obviously there'll be people who've been, I don't know, is it diagnosed with scoliosis, people who have it, and then they think they can't do certain things when they may be able to. So what's your sort of take, like in a generic sense, what's your take on that? So
with scoliosis, there's a spectrum of the condition. So if someone's got a mild scoliosis, they're likely to be able to do most things. I think Usain Bolt has a scoliosis, so he's like the highest performing 100-meter runner ever.
Yeah, but his biomechanics out the blocks are shocking, aren't they? So that's a bad example.
Terrible example. But then you've also got people that require surgery to stabilize their spine so that they're not compressing organs. So there's such a wide spectrum, and I'm not an expert on scoliosis. I certainly would get somebody else to give the initial diagnosis and advice, and then I will follow that advice. So if somebody's allowed to exercise and they get pain, then we'll take it slow. But we won't make the scoliosis the primary focus. We'll be looking at what can they do, what can't they do, how can we progress on to being able to run again or be able to pick their kids up. So as long as they are safe and been told by a specialist you're safe to exercise, then you start to look at that wider spectrum of causes of pain.
So moving forwards, from one of the things that we get a lot in that, what would you want to talk about next? So we've got a list of things, but what would you say the next thing after back pain would be?
At number 2.
Number 2. No, because so what would you say out of the things we listed earlier?
Do you want to talk about your foot?
Oh, talk about that. Yeah, so I've just been having this, and it happened a while ago, and then it just went, and it's not been I know some people get like this plantar fasciitis or pain in the kind of the heel or the arch of the foot that really is quite debilitating for them. All I've noticed really is, and it was probably a few months ago, I got a very low level, like bit of heel pain. But like I mentioned to you earlier, once I get up and start walking around, within 10 minutes, it's kind of almost 90% gone, you know. And at the moment, just this week, typical, we've got this big walking weekend this weekend. My my heel kind of flared up again. But just in the morning when I wake up, I'd get up, I'd hobble around for a little bit, and then, but like I say, by the time I'm at work and I'm walking around on my feet all day at the gym, I just forget about it, and then, you know, I might think about it and think, oh, that's gone, that's not there anymore, you know. So as soon as I actually start moving, or not as soon as, but within 5-10 minutes of walking, it kind of goes. But yeah, like a plantar fasciitis um type pain, that's very common actually, isn't it? You know, that we have a lot of
Yeah.
people come to. First of all, what is it and what causes it? Would you be able to start with that maybe?
Yeah. So for me, I'll treat it similar to a tendon, in the sense of it's a very stiff and a strong structure, and it takes a long time before it becomes irritated. But once it does become irritated, it's very difficult to manage. And there's like, I think you're saying that Jack, the podiatrist, might have been coming on there. This would be his area of speciality. But the idea around plantar fasciitis is that the attachment point onto the heel becomes irritated. So that's where you're saying that pain that just sits just sort of off the heel onto the soft tissue. That area is getting overloaded and then becomes inflamed. And that's why it's got itis at the end of the name, because there's inflammation involved. And for whatever reason, there might be weakness in the arch. There might be that you have just decided that you want to go and climb a mountain and you've never pushed yourself to that point, so that the area becomes overloaded. There's also a link between tightness in your hamstrings and calves. But this condition is extremely difficult to manage because it's taken a long time to get to the point where it becomes irritated for a lot of people. For yourself, it sounds like it's slightly milder case. And as long as you do the right things between now and maybe the next 12 weeks, that should disappear. The fact that you've got a walk-in weekend puts you a little bit of risk of it getting worse, because you will be on your feet a lot. So that's where that's going to be a challenging one.
Yeah,
we'll see how you are on Monday.
Yeah, that's what I find. If I do a day where I maybe do 15,000 steps plus in a day, the next morning it will probably be a bit more sensitive than, again, I don't want to say, it's not like I can't put any weight on it. It's just uncomfortable for the first few, you know, first 10 to 15 minutes, you know, of the day.
And that's how we diagnose it as well, because there isn't a clear test that says, right, you have plantar fasciitis. It's down to what the patient describes. So if their first few steps in the morning are really painful, but then it eases off, if after a period of time where they've been sitting and then they go to start walking again, the same pain occurs, but then it eases, that gives us the idea that it's likely to be plantar fasciitis over other things, because differential diagnosis might be a stress fracture of the heel, or it might be a tear, it might be a bone spur, and they respond differently to load than what plantar fasciitis does. So what you're describing is sort of the classical example of what plantar fasciitis is. Those first few steps are difficult. But if you ignore that and you just keep walking and walking and walking, the likelihood that pain will start to occur. So there is that delayed response as well.
So what would be the kind of the treatment for it that you would maybe give someone, maybe some exercises they could do, or what would you suggest as kind of like a treatment if someone's similar to me, you know, just starting to get that feeling? It's not terrible at the moment, but they're aware of something like that.
I would reduce your load, so that would be reduce your walking. So good luck.
Can I just say at this point, James has agreed to the disclaimer in the app. So just to put that out there.
Yeah, I'm definitely going to do the walk this weekend, but then yeah.
But it's not like you've broken your leg, so you can go and have the walk and suffer the consequences afterwards.
And also, a lot of what we do is going to be like on fields and grasses.
Yeah.
So it's not like walking on concrete. Do you know what I mean?
Yeah.
So it's, again, maybe
But simply, if you back off a little bit, then you tend to find that the symptoms improve. For you, I think we've got to try to think about what can you do to reduce the load through your plantar fascia, and that could be taping. So you might tape the plantar fascia just to take a little bit of pressure off of it. So that allows you to do a little bit more. You might find that throughout the day, some stretches will be really beneficial for symptom management, just to calm it down, because every time you rest, that's taking a bit of load off of it. So you might find that doing some stretches will be helpful. Pain
That's
relief.
what I find just going on like the bottom step at the gym or at home and just, dropping my heels and just really trying to stretch like maybe like around the Achilles and the calf and that kind of thing. That helps. I think that eases that. It certainly alleviates and eases the pain. Definitely.
There's a stretch that biases the plantar fascia as well. So if I don't know if you guys do like a knee to wall test where you push your knee towards the wall, you feel the stretch in your Achilles and your ankle and your calf. If you was to extend the big toe and then do the knee to wall test, you put more strain through the plantar fascia, and then that can be a little bit more targeted towards the area.
So do you do that just by pulling the big toe up, or do you manually pull the toe up and go into that stretch?
So if you treat that as the wall, put your big toe up against the wall.
Okay,
and then lean your knee forwards, then you'll start to put that stretch through the calf, Achilles, and underneath
that's
the
good
foot as well.
Yeah.
Oh, I like that.
Yeah, that's good.
I'm doing it right now on the bottom of my table. Oh, blimey, that's good, that. Apart from I've got gout in my right toe, so it's we'll get there.
It might help gout as well.
Apparently, James, walking on Lego is really good for it as well.
Yeah.
A lot of people do have these mats, don't they? That are like pebbles and stones and like that. So you're walking on it's meant to stimulate the nerves of the feet and things like that. I don't know if that's any good.
I've not come across that, but but what the thing is with any problem, because it doesn't get better, people will try so many different things, and if that one person finds it's helpful, they will tell people this is the approach to take. I'm more flexible now with if I've heard that maybe a certain shoe is a better shoe for you, I will discuss that. I won't just go, no, that's not the way that the research shows, because a lot of pain doesn't follow the research. It just follows what that individual tries, and rolling your foot on a ball or a bottle of frozen water might be helpful. But these are all very short-term symptom modifications. So for you over the weekend, anything that you can do that makes it feel that little bit easier will probably be good. So that rolling your foot, stretching, maybe taping, bit of massage when you get home.
Yeah,
we'll give you a king's chair.
Pete, you can do that. You can massage my feet, Pete. After all.
Yeah. All right, brilliant. Love it. I was going to ask about shoes actually, and again, it's down to the individual, isn't it? But how much does it matter?
I think it does matter.
Yeah. Because there's the thing of people I get a lot of people, because I wear barefoot shoes pretty much all the time now. My feet don't fit into anything else because I've worn them for so long that they've got bigger, and everything else just feels uncomfortable. But a lot of people will say, well, I can't wear those because I haven't got any arch support and all of that, which is a thing as well. But some people can. I'm saying some people can, right? You can tell me if I'm right here or not. But some people can strengthen their arch support and all that, and then eventually they may be able to wear them if they want to. But also, if you're going to wear barefoot shoes, but you're sitting down all day, then it's not going to make that much difference anyway, is it? So where's what's your opinion on all of that? Because it's a huge, you could argue about this forever on the internet, couldn't you? So
I think what you're saying is absolutely correct, is that somebody that sits at their desk all day and then starts walking in barefoot shoes, they may not have trained their feet up to be able to tolerate it. And if they've been wearing supportive shoes all their life and then adjust and then change to barefoot shoes, it's likely to cause some trouble because you're having to load your feet in a way that you haven't ever done before. So I'm not too strong in my advice towards what you should wear, but I certainly don't change people's footwear just because they've been told that they need an arch support. If they're comfortable, keep wearing the shoes you've always worn. If you're finding you're having problems, then it might be worth trialing a few different options. If you've developed a flat foot, because there's lots of people, like often women will find that they get this insufficiency and their foot starts to flatten as the years go on. And at that point, you will need something that gives you an arch or an orthotic that gives you more shape to your foot. But that's where I refer out to a podiatrist, because I can't distinguish normally between what shoe's better, what orthotic is better. That's not my area. But I do agree it's very important to have the right shoes, but don't change it just because someone's told you you've got a flat foot. If you're comfortable, if you've worked well all these years with a certain type of trainer, then don't keep changing, because that will cause other imbalances.
A guy, I was just thinking, like, it's a pity we don't know a podiatrist, isn't it? Otherwise, we could have asked these questions. But also, there's a guy who told me years ago, he had an Audi TT or something. He used to drive it around the roads and everything, and he was always checking his tire pressures. And I was like, is it that? But like, what difference does it make the tire? Like, if it's within, and he goes, the tire's the only thing in contact with the road, so it's very important. And I was like, yeah, that's a good point, actually. And basically, if you're moving around, you're on your feet, aren't you? So they're very important. And what you wear, what they're held in, is very important. So that's just reminded me of that, actually. Yeah.
Yeah, so I should say yeah. Dave is not the podiatrist that I've mentioned the last 2 episodes. That's Jack Kirby. Will hopefully be with us on with us this week. What we're doing at the moment, just to let you in a little bit behind the scenes, is that the Pete and I are both, it's coming up to the summer in England, and we both got a few weeks off. So we're kind of fitting multiple episodes into each week. So when we go away, we can still release an episode every Friday. That's why sometimes if I say the next episode is going to be this person and it's not, it's because we've slotted somebody else in so we can double up on some episodes, and not just because we're trying to catch up with Dan John and do 300 episodes.
No, exactly. But also there's an easy way around that, just not to say who's on next.
I know, but I can't help it.
And also, we're technically going on holiday together, which is a bit weird.
Yeah, we are. We're gonna have a few. Yeah, we have quite.
And you're going to be rubbing each other's feet.
Yeah, we're gonna have a few. We're gonna have a few weekends together over the summer. Yeah, no, it's gonna be lovely. Right. So yeah. So low back pain or back pain, non-specific back pain, whether that's the correct term or not, like you said, or if people like that term or not. Then also like plantar fasciitis, that was quite good. And like you mentioned, I've heard of that before, where you take like a can of drink or a bottle out of the fridge or the freezer that's really, really cold, and you put it under the arch of the foot, and you kind of almost do like a foam roller with it. But like you say, that's probably just going to temporarily ease the symptom and make the pain kind of go away and numb the area and make it feel better. It's probably not going to long-term change the condition, but it's kind of a short-term measure. But yeah, that at the moment, yeah, especially with it being this hot, that sounds like quite a nice one. The cold can or cold bottle. So I reckon we've got time for at least another one of these. So what would you say is next on your list?
So because we've spoken a lot about plantar fasciitis, which is a similar structure to a tendon, then maybe we'll talk about knee pain.
Knee pain is good. Yeah, well, knee pain isn't good, but knee pain is a good one for us to talk about, I think, because that's something, again, that we get lots and lots of people at the gym who kind of say, oh, I can't do lunges because of my knee. I can squat when both feet are, side by side, but I can't do lunges. Or maybe walking upstairs is an issue, or walking downstairs is an issue. Yeah, so maybe let's go on to knee pain now. Yeah, what are the sort of commonalities, or what do people come to you, expressing when it comes to knee pain?
So if it's someone who's coming from the gym, then it's quite commonly that they're doing lots of training that is knee dominant, and they've started to overload the knee. Whether that's because of a biomechanical issue or weakness in their hips, or it's something that's from a previous injury. So
I think, yeah, because obviously Steve Bush,
Steve Bush, yeah,
that's a good person to maybe talk about. And one thing you said on the last time, I can remember it 2 years ago. One of the things you said, which was really great, which made perfect sense, but I don't think I'd ever heard anyone say it before, was that most injuries either come from doing too much or doing too little. You know what I mean? Like if you're in the middle, you're okay. But it's when you try and do too much or you're not doing enough, you tend to get an issue. So yeah, maybe Steve Bush. Yeah, that's a good. Sure, he wouldn't mind us using as a case study. Yeah.
Yeah, Steve's been on your podcast as well, so people
Yeah.
might know a little bit about him. And
Yeah.
he decided after he'd had gastric band surgery that he was going to keep himself fit and strong, keep the weight off, and he's become like an avid gym goer. And he first came to me because he wanted to get involved with high rocks. And there's a lot of lunges within that, and we were trying to decide, does he get the partner to do the lunges? Does he try and start to integrate lunges into his training as well? And he's in his 60s, is he?
I think he's late. I think he's 59. So
59, so nearly 60. So sorry, Steve. He's in his late 50s, and he had knees that don't really tolerate load particularly well. So I explained to him that it's unlikely that he'll be able to get back to doing 20-kilo walking lunges, but he was very adamant that he wanted to try. So we just started off very slowly, tried out some lunges. As soon as his knee pain started to increase, then we stopped, and then we worked on something that wasn't knee dominant. He took that approach into his training, and he had a few setbacks, but managed that well, so that his pain settled down quite quickly. And then he started to be able to do multiple lunges and maybe 20 to 40 lunges in a go, which gave him the confidence that this might be possible. The trouble with Steve was that he was training for half marathons. He was training for lots of different events. So it was hard to keep him like sensible, because he would come off the back of his run, and the next day he'd be at spin. And for him, it all worked okay. He actually felt better after his spinning session, even after like a long distance run. But that was the challenge, is not doing too much that he then couldn't train, but doing an adequate amount that he could progress. And now he's doing the high rocks training with high rocks events with the 20 kilos, doing the full amount of lunges. And he's one that surprised me, because I looked at his condition of his knees, and I thought that it wouldn't get to the point where he could do it. And that's partly because he's willing to push into the pain threshold, but also we did it over a period of 18 months. And that's where most people will give up after a couple of weeks.
Because the thing is, I suppose with him being, in the past being like 30 plus stone as well, it's funny, isn't it? Because you obviously, when you're that heavy, you're putting a huge amount of gravity and load through like your back, your hips, your knees, your ankles, your feet, everything. But at the same time, I think I've said on this podcast before, when you've got people who've been like 30 stone, they're like exceptionally strong through their legs, like when they lose weight, because they've just been used to walking around with 30 stone. So the muscles, like people like David Kent before, who was at the gym, who lost like, again, 10, 15 stone. In terms of squatting and deadlifting, they're just super strong because they've been effectively like walking around carrying huge amounts of load. I mean, so there is obviously, it does take a toll on the joints. It must take a toll on the joints, I'm kind of assuming, but they've also got this kind of strength, and they've probably got pretty good bone density as well, because they've been, under this load the whole time. Is that correct, do you think?
Yeah, there's a whole like speciality looking at how being overweight affects your joints and bones. But that theory, it sounds quite reasonable, that if you lose a significant amount of weight, you're then able to lift more. Like in the gym, you're able to do more with less strain. So that could be a reason why he's coped better than maybe somebody that has always been a slimmer person. But there's like a chemical response when you are overweight as well. There's a chemical response that goes on because there's a lack of balance. So that can have a negative effect on your joint. So it's not just about the loading on the joints, but also the chemical and the molecular changes within tissues is negative as well as just having the extra load. So yeah, it's an area that I don't know enough about, but for Steve, he's done so much more than I was expecting, and mainly that's because of his personality.
I was about to say that, because from when he came on the podcast, he said after he'd had the surgery, they were even the dietitian and the consultant. I mean, he had it done privately, didn't he? And he said like the dietitian and consultant were like, "These results are amazing. How have you done it?" He's like, "I did what you told me to do," because nobody does. Everyone just goes, "Right, I'm done." But so that sounds like he's back to where he is. Well, he's got to, not even back to, he's got to where he is now at the age he is, because he probably did what you told him to do over that 18 months as well, or within a certain tolerance anyway, like 80% of it. And it seems like he has that personality.
Yeah, and I think he still has, it's like the back pain thing. He still has knee pain probably on like most days at a low level. And that's okay for him because he now can do so many more things. And it's when it creeps up that he then says, right, okay, I'm going to back off this week, wait for the pain to settle, and then go again. So he's not psychologically affected by the pain so much. He used to be. As soon as his pain creeps up, he was worried that his knee's gone. He now knows if it creeps up or he dials the pain up too much, he just needs to dial it down through rest, stretching, ice, maybe some anti-inflammatories if he really needs it. And then he gets back on track because he treats it like a long-term process for his whole life, not just, right, I need to be fit for this event. And if I'm not, then I'm just going to completely screw my knees up anyway. So yeah, he's much more sensible now, and it's worked. So yeah,
this is interesting actually, because like it's really hard to talk about this on this sort of thing because people can go away with the wrong idea. But pain is a weird thing, isn't it? Because if people get any pain, they're like, right, I should stop doing that. But then they might go and see a physio and they come back or see whoever it is, and they're like, oh, it was great. I felt so great afterwards. They really got in there and it really hurt. And it's like, why is that all right? But the other pain, that was like a 2 out of 10, isn't all right when you're in the gym. So where does that sit? Because like it's almost like it gets to the point where any pain is bad and you have to stop everything you're doing. But it's not always like that, is it? Because like you might prescribe exercises to someone that is sore, but like you've just said, if it goes above a 3 or a 4 or whatever, then you stop. So I mean, does that I don't know what my question is, I suppose, but like that's probably a misunderstanding, is it? Is that where people misunderstand stuff and can become, because again, psychologically that can build in the thing. If there's any pain, then there's a problem.
Yeah, I would say that you always have to push a little bit, because that will encourage a healing process. If you're constantly overloading, then that will. I was going to talk about the tendons, about disrepair. So if you're constantly overloading the tendon, then what's happening is it's not having a chance to heal, and then there's something called disrepair. So poor quality tissue will be laid down. That tendon will become weaker. They load it again, and then that becomes more painful. So there's this vicious cycle. If you load a tendon, give it time to recover, those tissues will then get laid down with better quality, and they will have a chance to align better, and then you're able to load it again. So loading within pain is okay as long as you give it time to recover, and then you load it again at a similar level, if not a little bit more, where the pain is no more. Give it time to recover, then push again. So you've got these incremental increases in strength, quality of tissue, but you have to do it over a period of 12 weeks. Otherwise, you'll just have disrepair, and then you'll just be back to square one, or if not, a little bit worse. So with most long-term conditions, you have to push into pain. Otherwise, you'll just sit on the couch forever. And it's about how much you push the individual, because I've gone away from that 4 out of 10 because someone will tell me, this is a 7 out of 10 pain. And I'll say, right, push into that for 5 seconds, have a rest. Then I'll say, push into that same exercise again. They go, oh, that's only a 5 now. And I'll go, okay, do that, have a rest, then we'll push again. So pain is adaptable. And if you listen to the 7 out of 10 pain, you won't actually do the exercise again. You have to repeat it, see if it gets better or worse, and then you adjust it depending. Sometimes you'll push into the 7 out of 10 pain. The next time will be a 9 out of 10 pain. So then that's a good sign that today is not a day to push.
But pain like that's a not relative, it's a subjective scale, I suppose, as well, because you probably get a Marine who comes in and goes, it's a 5, and his arm's hanging off or something like that. You know what I mean? It's like, oh yeah, it's fine.
Yeah, and that goes back to just treating each individual rather than if you had like a menu and you could only pick from that menu, you'd never be able to get what you wanted. But if you had someone come in and they say, well, we'll try a little bit of this, we'll get a Chinese menu, we'll get an Indian menu, we'll get an Italian menu, then we might find something that works for them, and then you'll be able to move forwards. But unfortunately, there's prescription, and then people stick to that too much, and then they don't actually get any better.
So I suppose from a tendon, you mentioned the tendon with regards to the knee, but we won't go into this deeply now, but I suppose that's a similar thing with one of the things we had written down was like tennis elbow and golfer's elbow, which a lot of people kind of have. And that's, I mean, from my not personal experience, but experience of working with people, and having Dan John on loads of times as well, when people are doing things like pull-ups, chin-ups, they start getting this elbow pain, which I presume is like a tendon type pain. But if they push that too much, that can take months to go, can't it? Like I suppose like plantar fasciitis as well. If you kind of ignore the creeping feeling, but lots of people, like you said, like even people at the gym, they want to just keep doing it. If it's part of a program, no, I've got to do it. I've got to do it. I've got to do it. And before they know it, they've got a real pain. They can't even hang from a bar. And then they've got this pain for like the next 3 to 6 months. And so that's tendon as well, elbow.
And then you're starting from scratch then, aren't you?
Yeah.
Whereas if you're able to train with the pain at a low level and work out what the adequate level is, after 6 months, you might still have some mild pain, but you're going to be as strong, if not a little bit stronger than you were at the beginning. So that is really the message that I try to give people is it's better to continually load at the level that you can tolerate rather than pushing it beyond what you can, having to stop for 3 months and then having to start your training all from the beginning.
Yeah, I mean that's one of the principles at the gym, isn't it? And we say it all the time: consistency beats intensity. You know, to do something. And when we had Ben Glasscock on the other week, he said, didn't he, about the most important things are consistency and adherence. You know, like if you're pushing yourself, smashing yourself to bits, and then you get injured and you can't do anything for 6 months because you're trying to go at 100% every time you train. Whereas if you go at 60 to 70% every time you train, you can train 3-4 times a week, 52 weeks a year. You will make progress, but you're far less likely to get injured, you know. So yeah, it's but like you say, it's personality types, isn't it? Some people feel unless they're giving it everything they physically can, they're not working hard enough. But so that's interesting because that's the same principle to training as it is to recovery, you know, which is great.
Yeah, that's loading to give adequate healing is exactly the same process as strength training. Is that you'll train 2 or 3 times a week with a gap in between. It then promotes some micro tears, if we think about it like that, which then creates a healing process. But if you don't give it time to recover, then you'll get disrepair. You'll end up causing an injury, or you just won't get strong enough. So it's exactly the same process, really, of like healing and strengthening.
Yeah. No, that's brilliant. That's really, really interesting. That's great. So we covered lower back, we covered plantar fasciitis, and then there at the end kind of touched on knee pain, tennis elbow, golfer's elbow, tendon pain, I suppose you could say, or across those. But we'll tell you what, we'll have to have you back on again, Dave, because we've got osteoarthritis, which I think would be really, really interesting to talk about, because especially that almost ties in with the knee pain and stuff as well, doesn't it? That we, potentially talked about. We've got osteoarthritis, we've got rotator cuff, shin splints, all those kind of things. So yeah, maybe not, we won't leave it 2 years, but We'll get you on again, and just
there's going to be someone with a shin splints going like, I've got to wait how long?
But no, mate. But that's really nice to take 3 or 4 conditions and just talk about it. Is a really nice, really nice format. That's great. No, brilliant. If people want to follow you, Dave, and Principle Physiotherapy, what's the best way for them to do so? What platforms are you trying to be most active on? Where would you like people to go?
So yeah, just Facebook and Instagram really is like Principle Physio is the name of the page, and then yeah, so they're the only 2 that I use really now.
Yeah, not TikToking at the moment.
No, not yet.
That made me laugh. What's it, Nancy? We had Dr. Nancy Allen on the other week, who's got to be, I don't want to, she's definitely in her 50s, maybe
Careful.
late 50s. No, but she is, because of what she said, how old her kids are. I was like,
yeah.
It's a GP. She's like in her late 50s. And she said, I love TikTok. I really love going on that, And I'm like, good. But
I've stayed away.
Yeah, we're having Nancy back on, aren't we, in a couple of weeks, I think.
So far, yes.
So far, yes. Brilliant. Okay, no, that's great. Brilliant. Yeah, so like I said, I will not say who we're going to have on next episode, because I've got a list of people who are coming on over the next few weeks, but I'm not sure who is next. So I'm not gonna. But we will hopefully have. Jack Kirby, podiatrist, because that would really be interesting to talk maybe in depth with him about the potentially like the plantar fasciitis stuff, but the footwear and the shoes and the feet and all of that. That will be really, really good. So yeah, hopefully we'll have him on in the next couple of weeks. Thank you so much, Dave, for joining us again. That was great.
No worries. Thanks for having me on.
Brilliant. Thank you, Mr. Peter Lant. Well, Dave, I'll be seeing you in about 2 hours.
Yeah.
And Peter Lant, I'll be seeing you. Well, in 24 hours' time, we'll be walking in Bath.
4 o'clock, yeah.
Yeah, we'll be walking in Bath.
We're seeing you guys at your digs.
Yes, you're going to meet us at the hotel. Yeah.
Yes.
No,
thanks, Peter.
Cheers, Dave.
Excellent. Brilliant. Thank you so much, Dave. Cheers, mate.
No worries. Thanks a lot, guys.
Brilliant. Thank you, mate. Right. Thank you so much, everybody. That was absolutely fantastic. Thank you. Please do like, share, subscribe, leave a review if you're watching or listening on a platform that allows you to do so. In fact, Dave, if you need to shoot off, you can shoot off if you need to, because I just need to read a review out, which we've had. Yeah, cheers, mate. Which I will do now, because I haven't read this one online. This was a recent review that we had come in. And it says the title is a 5-star review on Apple Podcasts, and the title is Versatile and Informative. And this was left just last week, I think. My current favourite podcast. I find it fascinating, informative, and always a joy to listen to. Keep up the great work. So thank you very, very much. That is from Baby Wilt. Okay, so Baby Wilt. Don't know what your real name is, but Baby Wilt on Apple Podcasts.
That might be their real name. You never know.
Might be a real name. If you can message us on Instagram or Facebook, or somehow reach out to us and let us know if you would like a t-shirt, a hoodie, a sweatshirt in this weather, possibly a t-shirt. And let us know, what size, what color, all the rest of it. Just touch base with us and where you want us to post it to, and we will send you out some free merchandise. So thank you very, very much indeed for that review. Yeah, do go on to Apple Podcasts and leave us reviews. That's where we're trying to accumulate them at the moment. Yeah, so thank you all very, very much. We will see you next week for episode 255 with a mystery guest. See you then. Bye-bye.